Are you living in pain? Is it joint pain or muscle pain? If so, stay tuned. Welcome to Living Pain-Free with Dr. Marc Darrow from the Joint Rehab and Sports Medical Center in West Los Angeles. This is the program that can give you effective solutions for the pain that you've been living with. Dr. Darrow is a medical doctor board certified through his studies at UCLA, and Dr. Darrow uses stem cell and platelet-rich plasma therapy to heal your body. He teaches about the use of stem cells, PRP, and prolotherapy. Today's program could open up a new life without pain for you. To speak with Dr. Darrow, call 866-870-KRLA. That's 866-870-5752. Ask for a copy of Dr. Darrow's book, Stem Cell and Platelet Therapy. Now, here's Dr. Darrow with his co-host, Nita Valens.
Well, hi there, Dr. Darrow and Dr. Grove.
How are you today, Nita?
Great.
Good morning, Nita.
Good morning.
Dr.
How are you
Grove,
guys
how are
doing?
you feeling? Dr. Grove, did you pump up yet this morning?
Oh, yeah, Doc. You know me.
I do know you, and I'm I'm in awe. I'm very grateful to have my associate, Dr. Grove, on the phone with us. I'm sorry, on the radio with us. And I love to talk him up because he's such a great guy. Who's squeaking chair there? We have to, what do they say? The squeaky wheel gets the grease or something like that? Anyway, we're here to teach people about how to end or diminish their musculoskeletal pain. Musculoskeletal infers things like arthritis, neck pain, back pain, hip pain, joint pain, toe pain, finger pain, bottom of the foot, plantar fasciitis. It doesn't really matter what part of the body because somebody's still squeaky because we can inject under ultrasound guidance, and Dr. Grove is, I think, probably one of the world's most in tune and most technically advanced in ultrasound needle guidance and diagnostics of anybody on the planet. He's had the highest level of training that there is, actually much better than my training, which came off the seat of my pants back in the old days. And I think he's probably one of the greatest injectors. Our patients love him, and I love him, and probably more than his parents at this point, right, Dr. Grove?
Hey, I stand on the shoulders of giants, Doc. You know that.
Well, I'm a short giant. We in the office we call it Big G. That's Dr. Grove, and Little D. That's me. I'm only 6 feet, but you tower over me physically. That's for sure. So anyway, what we're talking about today, while we're having fun here, is, by the way, we want to get some callers in here. If you want to call and talk to Dr. Grove or myself, Dr. Marc Darrow, the phone number to the studio is 866-870-5752. Grab your pencil and I'll repeat it for you. That's 866-870-5752. And we would love to talk to you. We're going to be very nice to you. We're going to love you. And we're going to take good care of you and answer all your questions about your own body and about your friends and your parents and your kids who have had injuries or arthritis and are in pain. So I distract myself many times over. If you call in, which I hope you will, we're going to send you a free copy of our book, Stem Cell and Platelet Therapy, Regenerate, Don't Operate. It's about 200 pages long, and it's got about 250 studies about how you can end your musculoskeletal pain without surgery. The byline of our show is Take the Surgery Out of Pain. That means our culture is changing rapidly in many, many, many ways, and we're moving from a surgical medical culture to a regenerative medicine culture. So, Dr. Grove, would you like to comment on what that means for you? I know that both myself and yourself come from a surgical background. Why aren't we doing surgery? Why are we doing injections instead?
Yeah. So, again, to have a conversation like this, you have to have both perspectives. You know, we're not just naysaying all surgery. Doc and I have both spent a lot of time in the operating room, seeing what the surgeries are like. And again, it's a very challenging field. We have the utmost respect for surgeons. Very regularly, they're the top of the class in your med schools. Really, really skilled individuals. But when you see the outcomes and you see the risks of some of these surgeries, and then you see the outcomes from regenerative medicine using platelets and stem cells, we don't really see the same risks. At the same time, we're thinking, what's the old motto in medicine is do no harm. So when you see the opportunity to not do surgery, get similar or most times better outcomes using these injections, we tend to be the conservative voice of reason and try to get people to not have so much of the risk from surgery, right? Things like infection, things like the artificial joint that you put in gets loose. Again, you have to replace these many times. The risk for anesthesia obviously is much higher than people led on to believe. Not to mention just the time, right? When you do injections with us, you're not looking at 6 months or a year, of rehab getting out of here. You walk out of the office, you give yourself a little bit of time to heal up, but it's a much faster healing time as well.
Yeah, we have a lot of people, and this sounds incredible, but it happens. We have people that come in for one treatment with stem cells or platelets, and we get a call like in a day or two saying that they're better. And that happened to my body. I've self-injected myself on both my knees and both my shoulders, both my elbows, my right wrist. I've had other doctors inject my neck and back. Being an ex-gymnast, if you want to say that, you're never an ex-gymnast. It's like being a cowboy. You never want to hang up your guns. But my body went through an awful lot, and Dr. Grove is the same. Dr. Grove is a gorgeous bodybuilder, and he was the captain of his football team for the Cornhuskers. So both of our bodies have been through a lot of sports injuries. I don't know anyone who's been injured more than I have, and I don't know anyone who has self-injected themselves as much as I have to heal all of it. And my success is 100% so far. I've been doing this for 27 years, and every time I've injected myself, I've healed. I've had some body parts that have been a little more resistant to healing, and it's taken my right shoulder, the first time I injected it, healed overnight after a failed surgery, which is pretty incredible. And I had about 4 years of misery. I learned about regenerative medicine. I injected my own shoulder one night, and I woke up the next morning 100% full range of motion, no pain, and at that point I committed myself to doing regenerative medicine for the rest of my medical career. So I love it, Dr. Grove loves it, and our patients love it. It's not going to work on everybody for many reasons, one of which is some people are too active and they refuse to wait for the healing and the cells to regrow. Some people are taking things like ibuprofen, which are anti-inflammatory medicine. The body needs a little bit of inflammation to sequester or bring to the area of the injury what are called fibroblasts, and they are cells that grow tissue. And some people, some docs don't inject with ultrasound. I even inject myself with ultrasound when I need it. So I can watch exactly where that needle, I can pinpoint where that needle goes to. There are studies that show if a doctor injects blindly, that about 1/3 of the solution doesn't even get to the point where it's supposed to go because the doctor is guessing. And then I have what I call the bad doctor syndrome, which are doctors that do this once in a while. They don't know what they're doing. They haven't been trained. All of my continuing education is in ultrasound-guided needle injection treatments. We use cadavers, and it's the best way because they don't scream if you hit the wrong spot. But when you're looking under ultrasound, you can actually see where that needle is going, and you can learn where to put it. And then there's the final thing, which is some people will get one treatment, and we have patients come back 2 weeks later for checkup. And at that point, we might inject again, or they may be better and leave it alone. And so it's the not enough treatment syndrome, meaning the person has the expectation, the patient thinks, this is a miracle, I'm going to get one treatment and I'm going to go fly to the moon. Well, it doesn't work like that. Everybody is different in terms of what their injury is or how much arthritis they have. Some people need a few treatments. And so we have to be careful to educate our patients. We have everyone sign a consent form saying they may need more than one treatment, but sometimes people come back at the 2-week mark when we re-examine them, and they go, I'm not getting another treatment, it didn't work. And we explain to you, we often spend, how much time do you spend with a new patient, Dr. Grove?
Typically. So our new patient visits, to me, is honestly probably the favorite part of this job for me, is when you're working for, a big corporate health entity, you're rushed in to see patients, you get a couple minutes if you're lucky. The patient's left not knowing what's wrong with them. You don't really know why or how you're getting the treatment they recommend. They don't have time to go over the risks, let alone the benefits of treatment. So our first visit that we have with patients is by far our longest visit we'll most likely have together. But I want to make sure that, we're having a proper history. We're having a proper physical exam where I'm putting my hands on you, right? And then we're doing a thorough scan with the ultrasound. Again, ultrasound's such an amazing tool we have at our disposal that now the definition is even higher than what you see on MRI. Plus, it's dynamic, meaning you're not just laying down still and I'm getting a still image. I'm moving the tissue around. I'm stressing the tissue. I can change the orientation of the probe, which is the device I actually use to look at the tissue. So we get a much better evaluation of what's going on. People always get a kick out of looking at the ultrasound in real time. Again, it's great for soft tissue, great for things where we can see very small tears. And we have a lot of aha moments where they think, oh, well, this is where my pain is, right? This is why I'm having the symptoms that we're having. And you get a lot more buy-in, a lot more comfort level from the patient.
Yeah, and that's really it's a big thing that we focus on this show every week, which is do not believe your MRI or your X-ray or your CT scan as the cause of your pain when you find something going on there. The old medical model, which I call the dinosaur model, is send someone for an image and then operate on the thing that doesn't look right. And that is just totally false, because we get so many people who come in who have, let's say, a rotator cuff in their shoulder, and we look with the ultrasound and we see that it's not even the spot where they're having pain. It could be the shoulder is very complex. The 4 rotator cuff tendons that attach, that move the arm, and there's the labrum in the joint, which is, labrum means lip in Latin, and it's a circular fibrocartilage piece that helps hold the humerus bone, the arm bone, into place. So a lot of times people have a labral tear and they're ready to get a surgery, or they have had a surgery on the labrum, which typically is removing part of it, smoothing it out, once in a while stitching it up if it's a really big tear. And then we find that they're ready for another surgery. The first one failed because, guess what? I have never had a person tell me who had a failed surgery that the doctor touched them to find out where the pain was. So they went off of an MRI or an X-ray, and they did a surgery based on that. They wanted to fix the MRI. We're not into fixing MRIs. I mean, we like to have an MRI because we find things like cancers and things that can be dangerous, and it may assist us in our diagnosis, but we use our hands. And the hands are the best diagnostic thing that there are, and it's unfortunate that doctors in this, quote, technological age don't know how to use their hands anymore. I know Dr. Grove is what's called a doctor of osteopathy, which has the same rankings as a medical doctor, MD, but the training is often much more exam-based. A lot of my MD friends don't even know how to do a musculoskeletal examination. What was your training in med school about using your hands, Dr. Grove?
Yeah, so again, I'm a DO instead of an MD. The basic way I explain the difference in education is it's the exact same amount of information that we're responsible for learning, exact same board exams you have to take. It's the exact same what we call the match system in order to achieve advanced training in your residency or specialty training in your fellowship. My residency was predominantly allopathic, or MDs, in that entire cohort at UT Southwestern in Dallas, Texas. But in terms of the training, we do everything chiropractors doing a lot more in our initial training. So for me, it's a really great tool and skill set when I'm doing a physical exam, right? So you can know what the anatomy looks like on a cartoon and a textbook, but in terms of finding it with your hands, which lends itself into ultrasound as well. It really completes the picture up. Because again, the big reason that we want to put hands on patients is we want to get to the core of somebody's pain, right? We don't want to just randomly be doing surgery on an area that doesn't look perfect on imaging. And the big reason for that is, again, do no harm. If these surgeries had no risks and they all had good outcomes, that'd be a totally different story. But
we would be doing them because we love it.
Yeah,
it's fun.
Yeah,
I mean, honestly, being in surgery is one of the most fun things I've ever done. It's a very male. Not that females can't do it, but it's a very male experience. It's like being on a sports team. And Dr. Grove, since you were the captain of the football team, the Cornhuskers, you know what it's like being with teamwork. It's fun. It's absolutely being fun, calling the shots and having the whole team work together. So surgery is fun for the surgeon, but it's not that much fun for the patient. And me having a shoulder surgery that failed, I know what it's like. I woke up and my arm was swollen like a balloon full of water, and I had a fever. And I was terrified, absolutely terrified. But, there's worse things that can happen. I've seen people actually die on the table from anesthesia. There was a patient that I had many years ago that came in for one issue, and as I was doing the history, I said, have you ever had any surgeries, or you ever had any other things medically? She says, well, I had a heart attack getting a back surgery. And I said, but you're 30 years old. How could you have a heart attack? She said, they induced me with anesthesia because I had back pain. I was going to have a back surgery. And then I had a heart attack on the table, and I woke up and I had to deal with the heart attack, but she said my back pain was gone and there was no surgery. And that's the weird thing about things like back pain or neck pain. They can come and go, and this woman had an MRI that showed herniated discs in her low back, which, to a surgical point of view, you want to cut out that material to get it off the nerve. But that was not her problem. She actually just had a sprain of the ligaments, the iliolumbar ligaments in the low back. I'm going to give out the phone number, so get your pencils. It's 866-870-5752. You can call the studio live right now. We'll send you a free copy of our book, which is Stem Cell and Platelet Therapy, Regenerate, Don't Operate. What that means is we can stimulate the body with platelets from your blood, PRP it is called, or stem cells, and we inject that at the spot where the injury is or the arthritis is. We can actually regrow collagen or cartilage in the joints. And don't believe your doctor if he says that can't happen. There's many, many, many studies. They're in this book. We're going to send it out for free. I'll even pay the postage. So there's 264 studies in here, medical studies, scientific studies on how platelets and stem cells work and how surgeries fail. And that's right, it's been studied. The VA Veterans Administration system now is not allowing meniscal tear surgeries in most cases because they find out, you probably know the most recent studies on this, Dr. Grove, that people who have the surgery or don't have them come out the same 6 months later. So why do the surgery? What's the point? So I want to give out the number. Go ahead, Dr. Grove.
Yeah. So in terms of meniscus, I try to read as much as I can in terms of what's the latest research on this. So if you have a meniscal tear, there's kind of two surgical options in terms of how they treat that. You can either repair it, meaning those are like really big tears, and they kind of suture or sew down that meniscus into the bone, allow it to heal. It's a much longer healing time, looking at a couple months typically for that. Or if it's a smaller tear, they'll do what we call a meniscectomy, where they actually just cut out part of that meniscus. A little faster recovery on that. So if you have your favorite pro athlete and you hear they have meniscus surgery and they're back playing within a couple of weeks, that's most likely what kind of surgery they had. So those are kind of the two main options. But like Doc said, the outcomes aren't great. One of my favorite studies I look at here, it's from the British Medical Journal, looking at complication rates for very common surgeries. So if you do a meniscal repair, meaning you actually suture that floating meniscus down back into the bone, complication rate, this is a study of almost 14,000 people, 18% complications, right? So that's, a couple thousand people being injured from the surgery. So again, this isn't people who had, neutral outcomes, meaning you had the surgery and didn't get better. This is people who had the surgery and they ended up worse. Same thing if you had a meniscectomy, meaning you're kind of clipping out part of that meniscus that's having that tear. A little smaller complication rate, still less than 1%, but it's a very common surgery. So this is a study looking at over 500,000 people. I think it was 15,000 people were injured from that particular study. And not to mention, the meniscus serves a couple of different purposes. It's a connection point for ligaments of the knee, in addition to providing some shock absorption for the knee. And when you clip out that healthy tissue, what we find is it speeds up arthritis, right? So when you have less cushion on that knee, not only do you not really get better from the surgery, but typically you buy yourself a fast track to having arthritic pain.
I mean, in my experience, when these surgeries are done, I mean, the surgeon typically tells the patient, if you don't get the surgery, you will have arthritis later in life. My experience is when they get the surgery, they have immediate arthritis because the tissue that protects and keeps the integrity for whatever joint, it could be the knee, it could be the shoulder, it doesn't really matter, it could be the hip, whatever it is immediate arthritis. And it's just a matter of time often before the joint will decrease in its integrity, and then another surgery is needed. And then if it's a knee, we're talking about a joint replacement, a knee replacement, which in my book is not a great surgery to do. If you ever saw one, you'd never get one. Any of these joint replacements, if you ever watched one, you'd never get one. You can go on Google and to youtube.com and watch some of these surgeries, and it's pretty horrific. It really is. So I'd be careful.
I would say, and again, the complication rates, right, for these surgeries, it's just, these aren't neutral outcomes, right? So people still must be getting better from them because they're still very common procedures. But again, to reference the study we just talked about in the British Medical Journal for knee arthroplasty, meaning they do a total knee replacement. This is a study looking at over 750,000 procedures. Okay, 14% complication rate. I mean, it's over 100,000 people that ended up much worse from that procedure. So, looking at these types of interventions, you just got to look at, are we actually getting better results for the patient? And then also, is it safe, right? I mean, that to me is a pretty good complication rate for a very normal procedure that everyone's aware of.
So let's talk about what you do, Dr. Grove, in order to heal the body.
Yeah, absolutely. So instead of, cutting out that tissue and operating on it, we'd rather regenerate that tissue and heal it. We find it's a much better solution for you. So in our toolbox, we've got a couple of things in terms of allowing that tissue to heal. We've got platelets. From that, we have a product called platelet-rich plasma. That's where we do a small blood draw from the arm, like you're given a blood sample. We take that blood, we spin it down in a centrifuge, and then we can take out the red blood cells, which can be a little bit too inflammatory, too irritating to tissue, and we're left with a nice golden color of PRP. P is certainly good. We can also use something called stem cells. A common way that we can get stem cells is through your body's own bone marrow. The way that we do that is we numb up the back of the pelvis. We use a small needle to pull some of that bone marrow out. Great thing about bone marrow is it's got both stem cells and platelets, so you don't have to use a blood draw for that one. But again, these are just two amazing tools that allow us to deliver these healing cells under ultrasound guidance in areas that we want to regenerate and heal.
It's so funny because when we mention taking bone marrow, people are like terrified. They're like, no, I heard my uncle had a bone marrow transplant. He said it was the most miserable thing he ever did. The way we do it is not like that at all. And I learned at UCLA how to do a bone marrow aspiration. And the patient on the table screamed. And he was from Bakersfield. I said, what did that feel like? He said, it felt like I was kicked in the ass by a mule. And we don't do that. And we use a very small needle. The whole procedure takes me about 15 seconds to do. It's like a blood draw. Very small needle. It's numbed up. And we slowly aspirate the bone marrow, which has platelets and stem cells in it. And the way most doctors do that for a bone marrow transplant is totally different. They'll take a giant CC and aspirate or suck out that bone marrow really quickly because they're in a rush, and then there's a negative pressure inside the pelvis that hurts. That's really where the pain is. So we're very careful about it. It's a very, really a very gentle procedure, and most people don't even notice that it's really happening. It's very simple. You just numb it up, and then we have a little drill with a little needle that has what's called a stylet in the middle, and we put the needle in just about maybe a quarter to a half an inch, and then we can pull out the stylet, put a syringe on that needle, and slowly draw out the bone marrow. And then some cases, like a knee, we're going to spin it in a centrifuge like Dr. Oh, hang with us, folks. We're going to a short break. If you want to reach us, call the studio, 866-870-5752, or call the office if you want more information at 800-300-9300. The website is www.jointrehab.com. We'll be right back. Thank you.
You're listening to Living Pain Free with Dr. Marc Darrow. Dr. Darrow's practice is located at the Joint Rehab and Sports Medical Center in West Los Angeles. To schedule an appointment, call 1-800-300-9300. That's 1-800-300-9300. Dr. Darrow will be back in just a moment. Stay tuned.